Rheumatoid arthritis (RA) is a chronic autoimmune disorder primarily affecting the joints, leading to pain, stiffness, and inflammation. While its exact cause is unknown, it's widely recognized that both genetic predisposition and environmental factors play crucial roles in its development and progression. One intriguing area of research suggests a strong link between oral health and rheumatoid arthritis. This video will discuss the latest evidence linking these two conditions and shed light on the potential implications for diagnosis and treatment. Over the past decade, a growing body of evidence has highlighted the connection between rheumatoid arthritis (RA) and oral health. In 2023, several studies provided new insights into this relationship, revealing shared risk factors, mechanisms, and potential therapeutic targets. Some key findings: 1. Shared epidemiology and risk factors. Evidence suggests that people with rheumatoid arthritis are at a higher risk of developing gum disease, which is characterized by inflammation and infection of the gums. Conversely, individuals with gum disease may also be at an increased risk of developing rheumatoid arthritis. According to a recent meta-analysis, the pooled results indicated that our patients had almost double the odds of having periodontitis compared to healthy individuals. 2. Microbial mechanisms and autoantibody generation. Research suggests that oral bacteria may play a role in generating autoantibodies, which are key drivers of rheumatoid arthritis. One notable bacterium, Porphyromonas gingivalis, produces a unique enzyme called peptidylarginine diamynase. This enzyme facilitates the conversion of arginine to citrulline proteins, leading to the formation of anti-citrullonated protein antibodies or ACPAs. Importantly, ACPAs are strongly associated with rheumatoid arthritis, and their presence can predict disease severity. Studies have demonstrated that antibodies against citrullinated peptides derived from P. gingivalis are present in rheumatoid arthritis patients and healthy individuals. However, they are found at much higher levels in those with active disease. Furthermore, P. gingivalis DNA has been detected in the synovial fluid of rheumatoid arthritis patients, suggesting direct translocation of oral bacteria to the joints. Lee and colleagues reported a remarkable 79% reduction in anti-CCP antibody levels after non-surgical periodontal therapy. Additionally, P. gingivalis PAD enzyme and LPs have been shown to activate monocytes and induce the production of pro-inflammatory cytokines such as TNF-alpha, IL-1 beta, and IL-6, all of which are associated with rheumatoid arthritis pathology. These findings highlight the potential contribution of oral bacteria and their products to systemic inflammation and autoimmunity. 3. Shared inflammatory and molecular pathways. Research suggests that rheumatoid arthritis and chronic periodontitis share common inflammatory pathways implicating key players like interleukin 1 beta, IL-1, interleukin 6, IL-6, tumor necrosis factor, alpha-TNF, and matrix metalloproteinases 8 and 9, MMPA, TEMP9. Elevated levels of these mediators contribute to tissue destruction in both joint synovium and periodontal tissues. This shared inflammatory profile supports the concept of an interconnected oral articular axis. Moreover, recent studies have shed light on the molecular underpinnings of this relationship. An integrative bioinformatics study identified 154 shared differentially expressed genes DEGs in rheumatoid arthritis and chronic periodontitis. Among them, protein tyrosine phosphatase receptor type CPPRC emerged as a central regulator associated with fibroblast activation, proliferation, and invasion in both diseases. PPRCE's role in mediating cell signaling pathways and immune responses makes it a potential therapeutic target for managing both conditions. 4. Clinical trials. Impact of periodontal therapy on RA activity. Evidence from clinical trials suggests that periodontal therapy may help manage rheumatoid arthritis. A randomized clinical trial involving 22 rheumatoid arthritis patients with severe periodontitis showed significant improvements after non-surgical periodontal treatment knee speed. The study found that knee-speed led to lower disease activity index DAS-28 scores at 2 and 6 months, indicating a reduction in disease activity. Additionally, there was a significant decrease in anticyclic citrullinated peptide to anti-CCP2 immunoglobulin GIGG, a key autoantibody in rheumatoid arthritis. These results suggest that periodontal therapy could be an effective complement to conventional rheumatoid arthritis treatments. Furthermore, another controlled study involving 66 individuals showed that knee speed significantly reduced DAS-28 scores. and salivary and plasma levels of receptor activator of nuclear factor kappa B ligand rankle and survivin. Notably, these biomarkers are correlated with rheumatoid arthritis activity. 5. Salivary biomarkers, a non-invasive window. Recent studies have explored the potential of salivary biomarkers for the diagnosis and monitoring of rheumatoid arthritis and chronic periodontitis. Research indicates that individuals with both rheumatoid arthritis and chronic periodontitis have elevated levels of interleukin-1 beta, IL-1, interleukin-6, IL-6, tumor necrosis factor alpha-TNF, matrix metalloproteinase 8-MMP8, and matrix metalloproteinase 9-MMP9 in their saliva. Additionally, rheumatoid factor RF and anti-citrullonated protein antibodies ACPAs are also found at higher levels. Network analysis revealed co-expression and interaction among these biomarkers, suggesting that saliva-based assays could potentially aid in the early detection and monitoring of both conditions. 6. Autoimmunity and inflammation amplification loops. Emerging evidence suggests that oral inflammation may contribute to the development and progression of rheumatoid arthritis through several mechanisms. Firstly, persistent inflammation in the oral cavity, particularly in the context of chronic periodontitis, may lead to breaches in the mucosal barriers. Secondly, low-grade bacteremia resulting from oral infections may facilitate the entry of bacteria and their products into the bloodstream. Together, these events can lead to the activation of immune cells and trigger systemic inflammatory responses. In rheumatoid arthritis, immune cells such as T and B cells play a pivotal role in driving inflammation and autoimmunity. It's hypothesized that oral inflammation may influence immune cell trafficking patterns potentially, leading to their accumulation in the joints. This accumulation can exacerbate joint inflammation and contribute to the development and progression of rheumatoid arthritis. Additionally, oral bacteria and their products may directly stimulate immune cells, leading to the production of pro-inflammatory cytokines such as tumor necrosis factor alpha-TNF, interleukin-1 beta IL-1, and interleukin-6 IL-6. These cytokines play a critical role in the pathogenesis of rheumatoid arthritis and contribute to joint inflammation and damage. Moreover, oral dysbiosis may also impact the composition and function of the gut microbiome, further influencing systemic inflammation and autoimmunity. 7. Therapeutic and public health implications. The bidirectional relationship between rheumatoid arthritis and oral health has significant therapeutic and public health implications. Firstly, it highlights the need for integrated management of rheumatoid arthritis, emphasizing the importance of routine periodontal evaluations. For patients, early diagnosis and management of periodontitis may be crucial for altering the course of rheumatoid arthritis. Secondly, periodontal therapy may serve as an adjuvant treatment for rheumatoid arthritis, potentially reducing disease activity even in patients already receiving disease-modifying anti-rheumatic drugs DMARDs. The impact of periodontal treatment on reducing inflammatory biomarkers such as serum amyloid A and C-reactive protein warrants further investigation. Thirdly, the use of salivary biomarker-guided monitoring could assist in identifying individuals at risk of rheumatoid arthritis and assessing therapeutic responses. Fourthly, targeting shared molecular pathways such as PTPRC may offer new avenues for therapeutic intervention, leading to more effective treatments for both rheumatoid arthritis and chronic periodontitis. Fifthly, understanding the bidirectional relationship between rheumatoid arthritis and oral health can inform public health strategies. Promoting oral health awareness and preventive measures among individuals with rheumatoid arthritis. This knowledge can also guide healthcare professionals in providing comprehensive care that addresses both systemic and oral manifestations of the disease. By 2025, mounting evidence has established a clear link between rheumatoid arthritis and oral health. Chronic periodontitis significantly contributes to RA pathogenesis and disease activity through shared immune pathways, including ACPA generation, elevated cytokines IL-1, IL-6, TNF, and protease activation. Periodontal therapy. Non-surgical debridement has demonstrated benefits in reducing RA disease activity and autoantibody levels. Emerging biomarker and genomic analyses identify molecular targets such as PTPRC, opening avenues for integrated oral rheumatic interventions. Further research directions include prospective cohort studies assessing periodontitis preceding RA onset and inflammation resolution post-knee SPEET. Larger arcs across diverse populations are needed to assess sustained impact of periodontal therapy on RA outcomes. Additionally, mechanistic exploration tracking microbial translocation and immune cell trafficking from oral tissues to joints is warranted. Finally, multi-omic profiling combining oral microbiome, salivary cytokines, gene expression, and our phenotype data may enhance our ability to model prediction and personalized management of this complex interplay. As our understanding of this relationship grows, it is evident that addressing oral health is not just beneficial but essential in the holistic management of rheumatoid arthritis. The future of rheumatology must integrate oral medicine for better patient outcomes. Thanks for watching. If you enjoyed the video, please share your thoughts. See you next time.